Welcome, everyone. I think we'll go ahead and get started. As people are joining, it's really wonderful to be able to welcome everyone to the 13th Annual Symposium on Global Cancer Research, hosted by the organizations shown on this slide. Next slide, please. My name is Satish Gopal, and I direct the Center for Global Health at the National Cancer Institute in the United States. And again, it's a real pleasure to be able to welcome everyone today. We're going to start with a few housekeeping notes. Can we go back? Yep. So simultaneous translation and closed captioning is offered throughout the symposium this morning in French, Spanish, and Portuguese. You'll have to select your language by selecting the interpretation icon, which is shown. I can just say next when we're ready to move on to the next one. By selecting the interpretation icon, which is shown on this slide, and to show closed captionings, you click on the CC icon at the bottom left of the screen. One important note is that while Portuguese is offered as a simultaneous live translation today, it's labeled, I think, in the interpretation icon as lingua latina or something. So just be sure to select that if you're desiring the Portuguese translation. Next slide. So some additional virtual symposium logistics. Our symposium today will be recorded and available on the symposium event site. For all attendees, please remain muted throughout the event. If you can see the slide but can't hear anything, please check your audio settings. Also, please confirm that your display name is correct. You can edit your display name by clicking on the 3 dots next to your name in the participant list. And there's an arrow shown how to do that. And then submit any questions using the chat box throughout this morning's symposium, and the moderators will try to address them as they arise. Next slide. A disclaimer is that this meeting is being hosted by the National Cancer Institute and in particular the Center for Global Health, but the views expressed in today's presentations and those are those of the speakers and don't necessarily reflect the views of the National Cancer Institute, the National Institutes of Health, the Department of Health and Human Services, or the United States government. Next slide. And I want to remind everyone that you can follow the NCI and the Center for Global Health on LinkedIn, and the LinkedIn handle is shown here. And if you are posting about ASGCR, please do use the hashtag, which is shown at the bottom right of this slide. Next slide. I want to particularly thank our scientific steering committee, who've been working for really the last year to help put this symposium together, including some adaptation that we have had to make along the way this year. So thanks very much to this extremely esteemed group of scientific colleagues who have helped organize this year's meeting and helped us adapt, representing a lot of different scientific areas, geographic areas, and institutions. So we greatly appreciate it, and ASGCR would not have been possible without their contributions. Next slide. Additionally, I'd like to thank our scientific abstract reviewers. We had a record number of abstract submissions this year. You'll be hearing from some of the select abstracts shortly, and sifting through all of the abstracts and assessing them for their scientific quality was really the work of the group shown here. Again, reflecting many different scientific areas, many different geographic regions, as well as many different institutions. So their contributions as well to this year's ASGCR have been really important. Next slide. I want to briefly preview this morning's agenda, particularly given that we're having an abridged ASGCR format this year. So I'll be finishing my opening remarks soon, and then we'll move on to the first half of the meeting, which is the oral abstract session, where the top scoring abstracts from this year's submissions will be featured in some brief talks. So really looking forward to that. Then we'll have a short break, and then following the break, we'll have the 10th Rachel Pearline Award presentation and keynote address. Then closing remarks, and we'll conclude today at 11:30 Washington, D.C. time. Next slide. I wanted to just show you the scientific abstract breakdown. So at the left of this slide are shown the various scientific areas of focus reflected in this year's abstract submissions for ASGCR. At the right are shown the geographic area of focus. Again, this has continued to be very diverse each year. And I think what we have sought to do is really feature scientific content that often doesn't get as much attention at some of the larger cancer meetings, and very pleased to be able to do that again this year, and pleased that there continue to be such strong submissions from the global cancer research community to ASGCR. Next slide. You can view all the accepted scientific e-posters and connect with abstract authors on the ASGCR event site. The site is shown at the bottom and the link, and then is also accessible using the QR code shown in the middle of this slide. Next slide. Some additional resources to note for the audience is there are always updates about funding for global cancer research and training shown on this, at the link shown on this slide. Many of our partnership and dissemination activities are can be found at the link shown. We have a spotlight blog that seeks to highlight work and researchers and cancer control experts doing work in LMICs, which is available at the link shown. And then also run a global cancer research and control seminar series for which archived and upcoming talks are available at the link shown at the bottom. Next slide. You can connect with the NCI Center for Global Health at our website, shown with the link shown here, at LinkedIn, as mentioned previously, with the link shown here. Subscribe to the CGH Exchange newsletter, and then all of this can be found and accessed using the QR code shown at the right of this slide. Before moving on, I wanted to make just a few other brief notes about this year's ASGCR, now having taking care of some of the important logistic information. This is the 13th annual ASGCR and the 5th time that we have done this virtually. That, of course, was an adaptation that was imposed on us by the global pandemic in 2020, but it is a decision that we have intentionally stuck with since then. We realized that by having this as a purely virtual format, it allowed us to hopefully occupy a niche that wasn't well addressed by many of the other signature cancer meetings that many of us look forward to attending each year, and also importantly allowed the NCI to support a meeting that featured work being done in low and middle income countries with virtually no barrier to entry. We've thought a lot about scheduling this meeting at a time that many people are able to join from other time zones and can access the meeting without any travel or any registration fees required. And so that continues to be our goal. And as a result of those decisions, I think we've seen a continued steady increase in participants from around the world each year in ASGCR, including many, many first-time participants from LMICs. And that's very much what we've intended to accomplish. And I think the virtual format, despite its limitations, has been a really important vehicle for allowing us to accomplish that goal. I also have mentioned that we adapted quite a lot this year. So normally ASGCR is held in May or the spring of each year, and we had initially intended to plan our usual multi-day ASGCR in May earlier this year. That was a particularly busy time at the NIH with the administration change, a lot of things happening, and so it just became logistically impossible for us to hold a meeting at that time as we had planned. And so we're tremendously excited that we've been able to adapt and have an abridged version of this year's ASGCR to feature some of the selected sessions that so many of you have been willing to join us this morning for this abridged format. We're already in the early planning stages of next year's ASGCR, and we'll again return, I think, to a multi-day format similar to what we've done in previous years. I think we're thinking potentially about moving this to the fall time slot to avoid conflicts with some other meetings that occurred around the previous May time slot, but much more to be forthcoming about next year's ASGCR soon. But just wanted to let everyone know that we are already in the early stages of planning next year's meeting. I also wanted to highlight this year that, reflecting the theme of new models for participatory research in global oncology, elevating the voices of patients and providers, we very much sought to increase the patient voice in the planning of ASGCR by including patient advocate representation on the steering committee. And I think you'll see that reflected throughout the program, including in this year's closing remarks. So this, again, I think has been a really important evolution of ASGCR and something that we hope to continue building on going forward, particularly to reflect the people who are most affected by cancer and ensure that the meeting is representing some of their interests and contributions as well. So with that, let me close my opening remarks and move on to the next slide and introduce my dear colleague and someone who's very well known to all of you, Professor Eduardo Casap, who will be moderating the oral abstract session. So Eduardo, over to you, and thank you so much.
Thank you very much, Dr. Gopal. Good morning, everyone. Good afternoon, good evening, whenever you are. I am Eduardo Casap, a medical oncologist based in Buenos Aires, Argentina, and very happy to chair together with Maggie Correa Mendez this oral abstract session. A few words about global cancer research. Global cancer research is a fundamental piece in global contract control. And we are not only talking about clinical research, the well-known phase 1, phase 2, phase 3. We need also to have information about statistics, epidemiology, cultural issues, healthcare systems research, and many other forms of research that are useful for a real global cancer diagnosis. Why? Because, as you know, data published in the international literature is mostly based in information of selected populations living in usually higher income countries. And that is sometimes a biased vision that does not reflect the real situation of patients and healthy populations in different regions of the world. So it is important to provide to the global community information about the cultural aspects, environment, genetics, molecular characteristics, and also technical aspects that are highly variable in different resources, settings, and economic situations, and also in rich countries. Because cancer care, it is not uniformly distributed even along rich populations. You have pockets of people, migrants, for example, or populations that are in war zones. Believe me, if we consider today the 8 billion people living in our planet, around 15, or at the most 20% have a correct and proper cancer diagnosis and treatment. And that is unacceptable because it is our obligation to improve equity and try to have better care for every person in different parts of the world. And it is important, I think, to also remark that this is not only a north-south information, we need to provide south to north information. Why? Because in many of the countries with limited resources, there are economic advances, there are better strategies, there are innovative tools that can provide the same or better results, lowering the cost. And that is a global issue. So we think that this initiative, led by the NCI of the US, but with the collaboration of different regional organizations of cancer around the world, it is a unique opportunity to provide new information, useful information, updated information to the world. about the real world situation about cancer. So a couple of final comments. Dr. Gopal also said that we have 5 years since ASGCR transitioned from a fully virtual format, and that allowed to broaden our reach. We will have 8 presentations spanning research in Latin America, East Asia, and East and West Africa, and it is very important that topics are covering a range of matters: pancreatic cancer, breast cancer pathways, HPV prevalence, pediatric cancer outcomes, stigma, and supportive care. And this variety of topics means that the world needs to consider very different aspects of the cancer problem. So now we will continue with this session, and over to Dr. Correa Mendez, the co-chair of this session. Maggie, please, you have the floor.
Thank you very much, Dr. Eduardo Casap. It's a great honor to be sharing this platform with you and to be Can you hear me okay?
Yes, we can hear you fine.
Yes.
Okay.
Yes, Maggie.
Apologies for that. My computer crashed here for a moment. But anyway, I was just expressing my gratitude for the invitation to co-moderate this session with Dr. Casap. I'm so sorry, I lost all of you. I think my computer is coming back. I can't see any of my screens. I apologize for that. Dr. Casap, can I pass it over to you, please, to introduce our first speaker while I troubleshoot?
Yes, yes, Maggie, give me
I'm so sorry for that.
1 second. I will open the agenda. Give me one.
Dr. Correa, we can see you and hear you okay. We have not
okay, I have it ready.
Okay.
Okay, thank you. I just lost my screens, but I have another laptop here ready. I can go for it, Dr. Eduardo Casap. Thank you so much.
Okay.
Okay, so it is my honor to introduce our first speaker for today, Dr. Dinul Ravel, from the Department of Surgery at the University of Sri Yawardenepura in Sri Lanka. And he will be presenting today on clinical pathological profiles of pancreatic cancer patients in low and middle income country, a single center study in Sri Lanka. The floor is yours, Dr. Ravel. Thank you so much.
Yeah, thank you. Can I know, am I audible?
Yes.
Okay, thank you. Good morning, everyone. So I'm Dinul Ravel, representing Department of Surgery, University of Sri Yawardenepura, Sri Lanka. So I'll be presenting on behalf of my colleagues. So our study explores the clinical pathological profiles of pancreatic cancer patients in a lower middle income country, specifically Sri Lanka. Next slide, please. To appreciate the most importance of our study, it's worth looking first at the bigger picture. So the pancreatic cancer is one of the deadliest cancers we have seen in worldwide, which accounts for a high number of mortality and morbidity. And also its impact is particularly severe in the resource limiting setting because the limited diagnostic facilities and the poor access to specialized care and a reliance on the palliative treatment. Next slide. So our study was aimed to describe the clinical pathological profile of our patients with pancreatic cancer, and we mainly focused on the demographic data and the clinical presentation and the pathological diagnosis and the management patterns they have undergone. Next slide. Moving on to the methodology. So our study was designed as a retrospective cohort study carried out at the University Surgical Unit of Colombo, South Teaching Hospital, Sri Lanka. And we were reviewed consecutive patients diagnosed with pancreatic cancer during 2018 to 2023, giving us a cohort of 380 individuals. And all the data were drawn from our department database and included the patient's demographic data, clinical history, and the tumor pathology and the treatment options they have undergone. And the data was collected and was analyzed using descriptive statistics. Next slide. With the framework in place, let's look at what our data actually revealed about the pancreatic cancer in our setting, beginning with the demographics. So we had 380 patients, including in our cohort. The mean age was about like 60 years with a slight male predominance. And most belongs to the ASA2 category, which means they had only mild systemic disease at the presentation. And the comparison with the global data, in US, the median age at diagnosis was around 71 years, so nearly a decade older than in our cohort. And there's a slight male predominance globally also observed, which is similar to what we observed. And this suggests our patients develop pancreatic cancer at a young age, possibly due to different risk profiles or early exposure of some risk factors. Next slide. Let's move on to the clinical presentation. The most common presentation of symptoms were observed is obstructive jaundice, followed by abdominal pain and loss of appetite and loss of weight. This reflects the late-stage disease presentation typically for pancreatic cancer. Looking at the global data, the pancreatic cancer cases was diagnosed after the disease has been already spread beyond the pancreas, which is locally advanced disease. And when the symptoms are already advanced, so this is consistent with our findings. Next slide. Looking at the pathological profile, adenocarcinoma was the predominant diagnostic pathologically, which is accounting for 46% of the patients and nearly half of the cases. And the majority of the tumors was located in the head of the pancreas, accounting for 71% of the cohort. And most of the patients presented with locally advanced disease, particularly PT3 tumors. And looking at the global data, worldwide, 80 to 90% of the pancreatic cancers were ductal adenocarcinoma, which matching with our findings, and only small fraction of patients in high-income countries are also diagnosed at the localized stage, which is the early stage. And most are also diagnosed at the advanced stage at presentation. So our findings mirrored the global data. Next slide. So let's move on to the management patterns we have observed in our study. So only a minority of the patients underwent surgery, accounting for 36% of our population. And only the minority, so nearly 2/3 of the patient received palliative care, mainly due to advanced disease at the presentation, poor resectability, and resource limitation. So again, comparing with the global data, in the US, only about 20% of fewer patients are resectable at the diagnosis. And even in the higher resource setting, the curative surgery is limited. But the patients still benefited from the wide access for the chemotherapy, radiotherapy, and multidisciplinary care. So both globally and locally, only a minority of the patient has undergone a curative resection, but the survival in Sri Lanka is likely to lower due to the limited treatment availability and the late diagnosis. Next slide. So moving on to the conclusions. To bring these findings together, I would like to summarize the key takeaway from our study and reflect what they mean for pancreatic cancer in Sri Lanka. So in summary, in our settings, the patients presented late, leading to poor outcomes, and the majority was older men with pancreatic ductal adenocarcinoma of the head of the pancreas, and the most are not surgical candidates. And palliative care remains the mainstay. And this highlights the urgent need for early detection of strategies and better diagnostic pathways and improve the access to the curative surgery in lower middle income countries. Next slide. So these were my references, and I would like to acknowledge my co-authors and the institution. Thank you.
Yes. Thank you very much, Dr. Ravel. Next, we have Dr. Ana Beltram for her presentation on oral HPV prevalence and genotypes among men living with HIV in Latin America and the Caribbean, preliminary results of the ULACNEG 201 trial. Over to you, Dr. Beltram.
Hello, I'm Ana Beltrame from the Moffitt Cancer Center in Tampa, Florida. And thank you for the opportunity to share the preliminary results on oral HPV prevalence and genotypes among men living with HIV in Latin America and Caribbean from the ULACNEG 201 trial. And this is an international collaboration between the United States and the Latin America and Caribbean, and is supported by the NCI to advance HPV cancer prevention. Next, please. Next, please. So HPV, human papillomavirus, is one of the major infectious causes of cancer, including head and neck cancers. And oropharyngeal cancer is most strongly associated with HPV. You can see in this figure as nearly half of the cases are positive to HPV DNA, mostly HPV 16. And so what is concerning in particular now is that the incidence of oropharyngeal cancer continue to rise. And next, please. The people living with HIV. Next, please. Okay, next, please. Next slide. Okay, so people living with HIV have a 64 higher prevalent incidence compared of the general population. But what we don't know is the prevalence of high-risk HPV, in particular high risk compared to the general population that is 3%. So the aim, no, can you go back, please? Could you please go back? No, back, please. Okay. So the aim of the study is to evaluate the prevalence of oral HPV infection and the distribution of HPV genotypes among men living with HIV in Latin America. And could you go ahead, please? So this is a cross-sectional study based on the trial ULACNEG 201. Please, can you go ahead in the next slide? Okay, this is a cross-sectional study using the baseline data of this trial that is a phase 3 randomized double-blind placebo-controlled study designed to evaluate the efficacy of the 9-valent vaccine in men living with HIV in Mexico, Brazil, and Puerto Rico. So we included men aged between 20 to 50 on antiretroviral therapy for at least 6 months who were sexually active in the past month. Next, please. And we excluded, next, please. And we excluded those with a history of any HPV-related cancer, prior vaccination, or a lesion, allergy to vaccine component, and AIDS-defining condition. Next, please. So we had the ethical approval from the 3 countries, and all participants gave the written informed consent. Next, please. So next, we collected the data via using a questionnaire. Next, please. And an oral gargle sample was collected to test 13 high-risk HPV and 12 low-risk genotypes with the SPF10 PCR system. A descriptive analysis was performed, and differences across country was assessed using the chi-square and ANOVA, or in case of the small cell size, we use the Fisher and the Kruskal-Wallis. Next, please. So we enrolled 700 participants, mostly from Mexico, with a median age of 35, and the median time since HIV diagnosis was 7 years. Only 80% had an history of AIDS, and the median CD4 count was 640, significantly lower in Mexico, you can see in the figure. And 91% of the participants had an undetectable viral load because they were in treatment. Next. So the data at the baseline, we know that, next please, 27.8% of the men had an oral HPV infection with a significant higher prevalence in Mexico, 32.8%, and the high-risk genotype were detected in 11% of the participants, with no significant difference across the countries. Next, please. According to the genotypes, next. HPV 16 was the most frequent high-risk genotypes, followed by 52 and 33. And most importantly, 8.7% of participants had a genotype included in the 9th valent vaccine. So in conclusion, next slide, the prevalence in our population, in people living, in men living with HIV in Latin America, had a high prevalence compared to the general population, 11% versus 3%. And the most common high-risk genotypes were 16, 33, and 52, included in the 9th valent vaccine. So, supporting the use of this vaccine. So we know right now the vaccine, for example, in the United States is recommended only for people aged 13 to 26 in people living with HIV, and they require 3 doses. But for the older adults, it's a clinical decision. So we hope that this trial will give crucial evidence to improve these international guidelines. Next, please. So in conclusion, I want to also acknowledge our principal investigators. Please, the next. Anna Giuliano from the Moffitt Cancer Center, Luisa Villa from the University of São Paulo, Grant Ellsworth from the Weill Cornell Medicine, New York, and Timothy Wilkin from the University of California, San Diego. Thank you so much.
Thank you, Dr. Beltrame. Moving on to our next speaker for today, Dr. Clement T. Nar from the Binka School of Public Health, University of Health and Allied Sciences in Ghana. He will be sharing, or they will be sharing with us around breast cancer care pathways of women presenting at district level and non-capital city hospital setting, findings from the ABCDO Ghana study. Thank you very much and welcome.
Thank you very much. I hope you can hear me well. I'm happy to present you findings from the breast cancer pathways of women presenting at district level and non-capital city hospital setting. I must say that it's a supplement from the NCI, and I'm happy to share it here. So this study is tied to a parent grant, which is the African Breast Cancer and Outcome Disparities from 5 countries that I'll show you subsequently. Next slide, please. Next slide. So by way of background, I mentioned a while ago that there is the parent grant, which is the African Breast Cancer Disparities and Outcome Studies. And the map to my right, you see 6 dots in black. This is where the original study has taken place, and it's like 7 years. It just ended with a 7-year survival analysis. What this study showed is that most of the breast cancer cases that they have in this belt of Africa are avoidable. And their 3-year survival also shows that in Black women in Nigeria, it ranges from 40% to about 60% in Southern African settings. Next slide. So what informed my choice of going to do breast cancer study in lower level facilities in Ghana, which are non-capital cities? It was influenced largely by the World Health Organization Global Breast Cancer Initiative 3 pillars. Pillar 1 is for health promotion for early detection with a goal of 60% invasive cancers that are supposed to be diagnosed either at stage 1 or 2, and having diagnostic workup within 60 days, and initiating comprehensive breast cancer management with a target of 80% undergoing a multimodality treatment. I'll share a few of these results. Next slide, please. So I had 3 broad aims. The first aim is among women recommended for breast biopsy, that's at district level hospitals in Ghana. If the woman cannot afford, the study nurse is able to recommend payment, and the study pays for diagnostic workup. We assess willingness to have the biopsy and receive results. 2, among these same women who receive results, we examine the subsequent treatment access to time. And then 3, we says that among women who receive histological confirmation of their malignancies or diagnosis at the district hospital, we examine treatment referral pathways. Next slide, please. So in terms of methodology, this is a cohort study, and then we did data abstraction. So basically, the data abstraction was at the whole teaching hospital. I'll show you a map subsequently. So we conducted face-to-face interview, which was done by trained nurses using red card that was built into tablets. We conducted interviews at different timelines. We have a baseline data collection. We have follow-up monthly, quarterly, and biannually. The database was hosted at IAC, and we had a pathology report from a private lab in Ghana. In terms of stakeholder engagement, we were able to link up with the International Agency for Research on Cancer, where my mentors come from, and they actually have the parent grant with the London School of Health and Tropical Medicine. And then also the Ghana Health Service Program for Non-Communicable Diseases, the Volta Regional Health Directory, and then the 6th hospital, as well as the Volta Regional Hospital. Next slide, please. So where was the study located? You see this box outlined in black. You can focus on 4 sections. On your top left, you see the map I showed for the parent grant. If you partition it into 2 vertical rectangles, on your left, that is the map of Ghana in blue lines, and then beneath it, right bottom, you see a black vertical box which shows the Volta and OT regions of Ghana, which has now been projected out to show the 8 different facilities. Point to note is the central part where you have facility number 4. That is where the whole teaching hospital is located. And that is the referral hospital for breast cancer treatment and management. It's also there that the University of Health and Allied Sciences has its main campus. Next slide, please. In terms of workflow, I would like you to focus on 2 lines and 1 color. So all the pink boxes and the pink arrows going down and the pink arrow going to your right shows each time point that a woman makes contact with a health facility and the event or particular activity that takes place. So upon contact, after consenting, the woman is recruited, biopsy is taken, BC diagnosis is confirmed, and then the woman either starts treatment or does not. All these different measurements, we are able to assess the time to diagnosis. And this time to diagnosis is broken down into the first contact with the facility, the contact to getting results, the contact to initiating treatment, and the overall from treatment, from contact with steady facility to treatment initiation. And beneath it is the list of measurement that is done at each time point. Next slide. Next slide, please. Okay, so by way of results, this is the flow chart. A total of 244 women were enrolled, of which we were able to collect biopsies from 190. We had all biopsy results received, and 54% were malignant, and 64% also initiated treatment. Next slide, please. Survival was low. Most of the women were late-stage diagnosis, and that's 61%. Median time was 14 days from first visit to biopsy, and treatment initiation was 76 days median time. Next slide, please. In conclusion, we have gaps in terms of late presentation and biopsy uptake and treatment at lower level facilities. However, pathology turnaround time was excellent. There's the need to streamline diagnosis and referral systems for smooth navigation. Next slide. In order to maintain this cohort, there is the need for active recruitment to continue and the need to expand breast cancer screening or research to rural and other lower levels of the healthcare system. And I'd like to acknowledge the parent grant holders. Next slide, please. Thanks to the MCI and the study facilities. Thank you.
Thank you, Dr. Nar. That was a great presentation. Moving on to our next presentation, and before we get into our Q&A, so I want to pause here and invite everyone to add your questions to the chat. I would like to invite to the floor Mr. Joao Paulo Fares-Inforti to share about hospitalizations for malignant pancreatic neoplasma in Brazil, an epidemiological analysis from 2019 to 2023. The floor is yours. Thank you.
Good morning, everyone. My name is João Paulo Fares-Inforti. I'm a medical student in my final semester at the Federal University of Health Science in Porto Alegre, Brazil. And today we will present our study on hospitalizations for malignant pancreatic neoplasm in Brazil, covering the years 2019 through 2023. We analyze demographic characteristics, regional difference, hospital outcomes, and their implications for public health. Next slide, please. Pancreatic cancer is an extremely lethal disease with a 5-year survival rate of less than 10%. Its incidence is increasing in Brazil, especially in the South and the Southeast regions. Risk factors include advanced age, smoking, obesity, diabetes, and chronic pancreatitis. Epidemiological studies are essential to guide prevention, early detection, and predictive modeling of pancreatic diagnosis. Epidemiological studies are essential to guide prevention, early detection, and predictive modeling of this aggressive disease. Next slide, please. The object of this study was to describe hospitalization trends for malignant pancreatic neoplasms in Brazil during the 5-year period analyzed. We compared demographic profiles such as age, sex, and race, evaluated hospitalization's outcome, including mortality and length of stay, and assessed regional disparities to inform public health interventions. Next slide, please. This was a cross-sectional, descriptive, and quantitative study using DataSUS, Brazil Public Health Database for the entire study interval. DataSUS is fed by the mandatory notification system, and reporting in this case is legally required, so not reporting them constitutes an ethical and civil crime. So the database is well populated with nationwide data. We included hospitalizations with a primary diagnosis of malignant pancreatic neoplasms and analyzed demographic variables, hospital outcomes, and regional differences. Next slide, please. Over the 5 years studied, there were 75,201 hospitalizations. The distribution by sex was nearly equal. Most patients were between 60 and 79 years old, followed by those are over 80. Regarding race and ethnicity, 48% white, 35% mixed, 5% black, and 12% others. In Brazil, about 44% of the populations identify as white, while around 56% identify as black or mixed race. Despite this distribution, elderly white patients remain the most affected group in the country. Next slide, please. The Southeast has the highest number of hospitalizations, representing 46% of the total. The South and the Northeast followed, while the North and Central West had the fewest cases. These charts compares hospitalizations with public distribution across Brazil regions. It shows how some regions, like Southeast, have hospitalization shares aligned with their populations, while others, such as South, show a higher share of hospitalizations compared to their population proportion. Meanwhile, the North shows a lower hospitalization rate compared to their population. Next slide, please. And the overall average length of stay of hospital was 6.4 days, with the North showing the longest average at 8.7 days. This find suggests that regional disparities exist, likely due to population density, access to healthcare, and availability of early diagnosis. Next slide. So the overall in-hospital mortality was 21%. Mortality was highest in North at 25%, while the Southeast and South had slightly lower rates. This confirms the poor prognosis of pancreatic cancer, especially in regions with limited healthcare infrastructure. Longer hospital stays and high mortality in the North suggest delays in diagnosis and limited access to timely treatment. Next slide. So in conclusion, hospitalizations due to malignant pancreatic neoplasm in Brazil predominantly affect elderly white patients. We observed regional disparities in hospitalizations number, length of stay, and mortality. High mortality underscores the poor prognosis of pancreatic cancer, and these results highlight the need for early detection programs, better healthcare infrastructure, and equitable oncological support across regions. Next slides. So thank you so much for your attention. And below we have the bibliographical references.
Thank you very much, Mr. Forti. We now are going to move on to our next brief session of Q&A for our speakers, our first 4 speakers. And we have a couple of questions in the chat, but I invite others to keep adding those questions so that we can ask them to our speakers. I would like to ask the first question that we have for Dr. Ravel. What do you think can be done or implemented to improve early detection of pancreatic cancer? Dr. Ravel.
Yeah, thank you. Am I audible?
Yes, we can hear you.
Yeah. So we were having a lot of patients when we encountering a lot of patients in the clinical setting, which used to have a later presentations. So I think we have to engage in the, so we have to implement more early detection, the screening methods, it is possible to identify the early as possible, because when it is going to the advanced stage, the resectability is getting impossible. So, and it will be account of higher mortality rates. So implementing, finding out new screening methods, or doing research on the lot of biomarkers which can present early in the disease, and screening for the people who are having the cancers familiarly. Those are my suggestions to improve the early detection of the pancreatic cancer.
Yes, go ahead. Thank you very much, Dr. Ravel. I would like to invite all of our speakers to turn their cameras on so we can make you visible for our audience while we go over this panel Q&A, please. Great, thank you. And I would just like to amplify also the kudos on the chat for these excellent presentations. The next question we have in the chat is for Dr. Nar. What are some reasons for the prolonged treatment initiation time for breast cancer patients after having a 2-week diagnosis time? Over to you, Dr. Nar.
Thank you. So we have 3 breakdowns for those ones. And the first one has to do with death occurring before treatment initiation. And that is one. And then we have health system related factors like the patient or the women have not been recommended treatment. And then we have patient level factors such like they don't have money for treatment. So one of the things at the moment is the Ghana Health Insurance actually pays for basic treatment for breast cancer. However, the distance to accessing care, it's a challenge. So facilitating breast cancer diagnosis, if the woman cannot pay at a steady pace, vis-a-vis the use of postal service to ship the sample to Accra, makes the diagnostic time round shorter compared to treatment initiation that has to now go through the routine system. Thank you.
Thank you, Dr. Nar. That's for your great response to that question. The next question we have coming from the chat is for Mr. Forti. Are the pancreatic cancer risk factors different across different groups in Brazil?
We don't have a very specific difference between the risk factors. The incidence in pancreatic cancer in Brazil must be the same around the country, but we have so many disparities in diagnosis. So in the north regions, possibly the patients die without a diagnosis, while in the south we diagnose so much because we have more biomarkers disponibility, TC and MR. So the diagnosis is the biggest difference around the country, because we don't have a very specific difference in the risk factors around the country in other neoplasm. So we can infer that in pancreatic neoplasm, we don't have this difference too.
Thank you, Dr. Forti. And please, if anyone has any follow-up questions, please feel free to add them at the chat as well. And I'll do my best to moderate, but I'm excited to see that there's lots of questions coming in. Dr. Beltrame, I see a question here around HPV vaccination. What was the HPV vaccination history of participants with a positive test for oral laryngeal cancers? And they also thank you for your wonderful presentation.
Thank you. So can you repeat the question, because
Yes, of course. They're asking about HPV vaccination history for participants that had a positive test for oral laryngeal cancer.
Oh, no, this is not our,
Okay.
yeah, it's not now our aim. We are doing this trial just for the oral infection and to follow the patients in this cohort of patients of participants for several years, and we don't have data on other cancer. Yeah.
Okay, thank you, Dr. Beltrame, for clarifying that.
Yes.
I see a couple of follow-up questions for Dr. Rabel here. The first one is, what is the survival rate post-surgery for pancreatic cancers that you see in your center? And yeah, let's go from that, and then I'll follow up with the next question.
Yeah, so we have done this research because there's limited data in the survivability in our country, because it's not much prevalent. Only 1 in 1,000 person will be getting it, so it's not prevalent. And so therefore, that's why we are conducting this research. That's our main focus. And this presentation includes our preliminary data. So we'll be following up this patient to assess this survivability. So it will be presenting later. So that's why we are doing the research, because limited data is available in this aspect.
Wonderful, thank you. And then also another question for you. What specific limitations does your hospital face in the treatment of pancreatic cancers? And they're asking for examples around limitations in chemo or radiotherapy.
Yeah, basically, so Sri Lanka is a low-income country, and recently has undergone a crisis, financial crisis as well. So it's basically in Sri Lanka, only one center is available for chemotherapy and radiotherapy, mainly for the radiotherapy, which is the Cancer Institute of Maharagama, which is all the country, from all over the country, the patients are presenting to that center. So there's a huge burden in the health burden because of all the people in the country is coming to that center. So therefore, most of the patients has to wait in the waiting list to take the radiotherapy. And because of the financial crisis, there's not much drugs are available in our country. So those are some limitations. If we can go to develop these things, I think we can improve the survivability in pancreatic cancer. Thank you.
Thank you, Dr. Raul, for providing that information. Next question we have is for Dr. Nar. How accessible is radiotherapy throughout your country?
So it's not too different from what my colleague just said. So in Ghana, we have all in the capital cities of Accra and Kumasi. And intermittently, they break down. So from that long stretch I have shown you for that whole study area, we don't have a radiotherapy in the region. It's chemo. And even for the chemo, if you look at the map, if you remember, they're up there, they need to travel like more than 200 kilometers to even access chemotherapy. So the disparity is great. And until we are able to fix that disparity, the late stage cannot be solved. Thank you.
Thank you. And I see another question for you, Dr. Nar. What is the time after treatment for breast cancers in your region?
Sorry, come again.
The question, let me go back here to the chat. Thank you everyone for adding questions. What is the TAT for breast cancers in your region? And perhaps guess who asked the question. We can clarify a little bit for that.
I will try.
Thank you.
So we are trying to do a short report on the TAT. So far, the closest I have seen is from Botswana, I guess, but I haven't seen any report yet. We are now looking at the TAT, and like I mentioned, we are looking at it in the different scheme I showed from the study recruitment diagram, when the woman first made contact with the facility to when you get a histopathology report to when you initiate treatment. What I reported here is just the median time, which we show like the fastest of 14 to diagnosis, and then the 76 median days to treatment initiation, if I get the question right. Yeah.
Thank you, Dr. Na. So to allow to continue with time, we're going to continue with our presentations for today, but please, if you see other questions in the chat that are directed to you, please go ahead and answer them in the chat as well. And for everyone in the audience, feel free to keep adding questions for our speakers as we continue with the next set of presentations for the day. Again, thank you very much for excellent presentations. It's been really insightful to learn from all your work. So please join me in welcoming our next 4 presentations for our session today. For the first one today, we'll have Ms. Deborah Jasmine, who is a graduate medical student at Duke Medical School in Singapore. She will be telling us about her work on evolving pediatric cancer outcomes in Tanzania, an 8-year retrospective study. The floor is yours, Ms. Jasmine.
Hi, thank you, Dr. Margarita. Next slide, please. Hi, my name is Deborah, and I'll be presenting on the Evolving Pediatric Cancer Landscape in Tanzania, a 9-year retrospective study. Next, please. So pediatric cancer rates, survival rates differ greatly between countries. In high-income settings, the 5-year survival rate actually exceeds 80%. But in low and middle-income countries, where actually half of the cases occur, survival rates remains critically low. So by 2050, it is projected that half of all cases are expected to occur in sub-Saharan Africa, and this is because the population there is much younger. But the estimated 5-year survival is only at 8.1%. So to address these disparities, Duke Global Oncology partnered with Bugando Medical Center in Tanzania in 2014. So BMC is one of the only 3 cancer centers in the country. It serves a population of around 14 to 18 million people. It is estimated that there are 1,100 new pediatric cancer cases that occur annually in this region, which is in the northern part of Tanzania. And since 2014, several interventions have been implemented to improve the pediatric cancer care there. This research aims to evaluate the pediatric cancer landscape at BMC from 2014 until 2022, focusing on survival outcomes as well as the diagnostic trends. Next, please. So this study is a retrospective data review. We reviewed nearly 2,000 records and then excluded patients before 2014 or after 2022, those above 18 years old, as well as patients with a confirmed non-cancer diagnosis. Then we were left with 1,500 patients that we used for the analysis. But for the survival analysis alone, we further excluded another 500 cases due to either incomplete or unconfirmed data, and year of intake of 2014 and 2015 because of the lack of complete data for those 2 years. So for the survival analysis, it includes almost 1,000 patients starting from 2016 until 2022. Next, please. So of the 1,500 patients, 56% were male, 44 were under 5 years old, and about 1/3 is between 5 to 11 years old. And when grouped by the cancer types, lymphomas were the most common overall, with almost 400 cases spanning the 9 years. Next, please. And one of the key findings of this study is that there is a steady increase in diagnosed cases over time, with more than twice as many cases in 2022 compared to 2014. So an earlier study reported that there were around 300 pediatric cancer cases that presented at BMC from 2010 until 2014. And this makes up only 5% of the estimated cases, which is the data point on the left side. By 2022, this number has risen to over 20%. So many of the healthcare workers at BMC actually accounted this due to the increased awareness of healthcare providers as well as community members regarding pediatric cancer, because the team has been doing outreach programs throughout the years. Next, please. And with regards to diagnosis, the three most common pediatric cancer is in Bugando Medical Center is Wilms tumor, Burkitt's lymphoma, as well as retinoblastoma. And what all these three diagnoses have in common is that they present with enlarging masses that you can visibly see. So this contrasts with global trends, where the most common pediatric cancer is acute lymphoblastic leukemia followed by brain tumors. So leukemia and brain tumors are harder to diagnose in Tanzania because it can present with non-specific symptoms and there are limited diagnostic capacity. And because of that, before 2014, there was actually no brain tumors identified at BMC. Next, please. But starting in 2014, there was newly identified cancer types, which includes brain tumors, that actually began appearing in the records. So initially, it was labeled as unspecified central nervous system tumor. But then as the years progressed, as diagnostic capacity improved, particularly with the availability of CT scans and MRI in later years, more specific diagnosis became possible. So then you have your ependymoma, your astrocytoma, medulloblastoma, and so on. And additionally, there are also other cancers such as bone cancer, osteosarcoma, and NCC, nasopharyngeal carcinoma, that began to be recognized as well. So basically, this indicates an overall improvement in the diagnostic capabilities at BMC. Next, please. And in terms of survival outcomes, the 1-year overall survival rate is at 46.4%, 2-year at 35.2%, and the median survival time is at 10.5 months. The graph is on your left, and event-free survival was much lower as many patients either abandoned care or experienced relapse. So the 1-year EFS is at 27.9%, 2-year EFS at 18.6%, and the median survival time of 3.7 months. Overall survival was significantly affected by diagnosis, but was independent of factors such as the patient's sex, age, year of intake, or travel time to the hospital. And survival rates also varied year by year, with the lowest in 2017 and the highest in 2022, where it reached 40.0%. Next, please. And here are some of the programs that the team has worked on over the years, which has helped to improve pediatric cancer outcomes at BMC. So this includes having a prospective registry development since 2014, establishment of a hostel so that patients and their parents can stay near the hospital while they are receiving treatment in effort to reduce abandonment rates, training for both healthcare as well as community members to increase awareness of cancer, as well as the initiation of tumor board to discuss more complex cases in order to provide better management for patients. Next, please. So in conclusion, over the first 9 years of the Duke BMC partnership, there have been notable improvements in diagnostic and treatment capacities. And this is reflected in increased case detection, broader diagnostic diversity, as well as improved survival rates. However, survival rate still remains far below WHO's global initiative for childhood cancers target of 60% by 2030. Therefore, sustained multisectoral efforts are essential to bridging this gap and improving outcomes for children with cancer in the region. Thank you very much.
Thank you very much, Ms. Jasmine, for a wonderful presentation to get us started on this second part of our session today. I see some of our previous speakers are answering some of the questions that we had left in the chat. Thank you for doing that, and please continue to do so if you see any additional questions for you. I would like to welcome next Dr. Richard Mone, a medical doctor from the Bugando Medical Center in Tanzania. He will be sharing his work about impact of community education program for retinoblastoma in Tanzania. Welcome, the floor is yours.
Thank you very much. As introduced, I'm Dr. Richard Mone from Bugando Medical Center, Tanzania. And I'll be taking you through my abstract, impact of community education program of retinoblastoma in Tanzania. So next, please. Next. So okay, more than 85% of the newly diagnosed pediatric cancers, which is for 400,000 globally, occurs in the low and middle income countries. And in this country, there is limited awareness and inadequate healthcare system, which contributes to poor outcome. And so retinoblastoma is the most common pediatric cancer, and it is curable if diagnosed at early stages. But the mortality is almost 100% with later stages. So in my country, Tanzania, more than 70% of the retinoblastoma patients present with late stages, and the survival is almost less than 30%. So our studies was aiming to pilot a multi-component education intervention, which might improve community awareness of retinoblastoma. Next. Next, please. So to address the knowledge gaps in the community and the retinoblastoma misconception, we use the culturally adapted media such as posters, retinoblastoma educational songs, and in personal community-based education and screening events. So to make this possible, there's some development like we use the local traditional dance groups, and we educated them of what we want to do and the importance of it. We also gave them a message which will need to be passed to the community. So they created a song which was entertaining, also educative, and it was culturally appropriate to that community, and it was performed during our community event. Next. Next, please. So, and again, we also did the healthcare provider training in one of the health center in the region. So what we did, we trained them on the common signs and symptoms of retinoblastoma. We also trained them on the arc-light use for screening of retinoblastoma, and they had chance to practice on one another, and also they practiced at the community event. We also did a radio talk. So what we did, like we randomly assessed like the most common radio that the citizens of that place listen to. Then we use that radio to educate the community on the signs and symptoms of retinoblastoma, the importance of early diagnosis, the viable treatment options, and we had sessions for questions and answers. So for analysis, we had we did a pre and post design study, which surveyed 100 participants, 50 from the case and 50 from the control, which was done before and after the intervention. The aim was again to assess the community knowledge, attitude, and screening up. And then the impact of media exposure was correlated with the intervention outcome. Next. So the result of finding like the result of our study was like 60%. There was a 60% increase the knowledge score in the interventional group compared to the control group. Like in the control group, there was no change. And then there was favorable attitude toward the chromosomal screening increased in the interventional group from 32% to 100%, while remain unchanged in the control group. And again, among the media that we used to pass the information, the radio was the most impactful, with 70% of the participants exposed, followed by attending the awareness event, and the rest was the community poster by 8%. Next. So in conclusion, like a multimedia component intervention combining radio-based education and community events and poster training significantly improved the glioblastoma awareness, attitude, and early diagnosis uptake in lower and middle income settings. So these findings underscore the importance of tailored educational strategies and healthcare capacity, including in reducing childhood cancer disparities in resource limited settings. Next. So yeah, those were my references. I would love to acknowledge the Bugando Medical Center team and the ECU Medical Institute, together with the DMC Group research collaboration. They were really supportive in this research. Thank you.
Thank you, Dr. Monet, for an insightful presentation. I really like seeing questions coming in the chat. Please continue to do so. Would like to welcome our next speaker, Dr. Catherine Sivanoff from Memorial Sloan Kettering Cancer Center, who will be sharing her work on understanding colorectal cancer-related stigma in Nigeria, a qualitative analysis. The floor is yours, Dr. Sivanoff.
Thank you. Good morning, everyone. As said, my name is Catherine. I'm a general surgery resident at Washington University in St. Louis, and I recently completed a research fellowship in global oncology as part of a longstanding collaboration between the Memorial Sloan Kettering Global Cancer Research and Training Program in New York City and the African Research Group for Oncology based out of Ile-Ife, Nigeria. I'm grateful to have the opportunity to share some of our work on colorectal cancer-related stigma in Southwest Nigeria. Next slide, please. These are my disclosures. Next, please. Colorectal cancer is the third most commonly diagnosed and second most fatal cancer worldwide. Mortality rates are disproportionately high in low and middle income countries due to limitations in national cancer control programs and health systems infrastructure. Next. As the burden of colorectal cancer continues to grow, implementation of effective screening and early diagnosis programs, which we've been hearing a lot about today, will be critical for addressing these outcome disparities. Successful implementation will not only rely on affordable access, but also on community awareness and perceived acceptability of these services. Next, please. Cancer-related stigma poses a major barrier to cancer screening uptake and early diagnosis. Next, please. Cancer-related stigma has been defined as a social process characterized by the exclusion, rejection, blame, or devaluation resulting from experience, perception, or anticipation of negative social judgment owing to a person's health condition. From this definition, manifestations of stigma have been divided into two major categories: enacted stigma and felt stigma. Enacted stigma involves direct experiences of discrimination or exclusion by external sources, whereas felt stigma involves perceptions of stigma, internalized stigma, or fear of or anticipated stigma. Next, please. With this framework in mind, we performed a qualitative study exploring perceptions of colorectal cancer-related stigma in Southwest Nigeria. Our study included patients receiving treatment for colorectal cancer at Obafemi Awolowo University in Ile-Ife, Nigeria, which is a large tertiary referral hospital in Southwest Nigeria. It also included patients' caregivers and their healthcare providers. From September 2022 to April 2023, we recruited 20 patients, 31 caregivers, and 16 healthcare providers, including physicians and nurses, for participation in 42 in-depth interviews and 4 focus group discussions. Interviews were conducted in the language of preference of the interviewee, including Pidgin, English, and Yoruba. They were recorded, translated as needed, and then transcribed for further content analysis. Next, please. Using content analysis, our aims were to identify themes related to drivers, manifestations, and impacts of colorectal cancer stigma, and to identify potential strategies for mitigating stigma in this region. In the following slides, we've organized our findings according to a health-related stigma framework developed by Rai and colleagues in 2020, with representative quotes for each theme. Next, please. Drivers of colorectal cancer stigma included psychological drivers, which were often rooted in fear, fear of death, fear of contracting disease, or fear of being spiritually cursed or attacked. Next, please. Social drivers were often rooted in the blaming of patients for their cancer diagnosis, ascribing the source of cancer to immorality, promiscuity, or waywardness. Next, please. And lastly, biological drivers of CRC stigma were rooted in the physical perceptibility of the disease process, which often related to bowel dysfunction and colostomies, especially if they were leaking or not properly pouched. Next, please. Manifestations of colorectal cancer-related stigma included enacted stigma, which most often involved relationship distancing, social exclusion, and discrimination. Next, please. Internalized stigma resulted in shame, resignation, and social withdrawal among patients. Next, please. You can advance twice for this one. Thank you. And then perceived stigma and anticipated stigma were also very common and led to non-disclosure of disease symptoms or diagnoses. Notably, while some participants described examples of enacted stigma, many stated that they did not actually experience stigmatization, rather they were kind of fearful of or had internalized stigma. Over half described positive reactions to their diagnosis disclosure in the form of support and encouragement from friends and family, suggesting that colorectal cancer stigma may be decreasing as community awareness and outcomes improve. Next, please. The impacts of colorectal cancer-related stigma included social impacts, which ranged from low support to total abandonment. The social impacts of colorectal cancer-related stigma were also described to disproportionately affect patients from marginalized socioeconomic backgrounds. One patient said, as you can see on the right side, they can be empathetic if the person is influential and known, but if the person is not known, nobody cares. If they are buoyant in the society, they will sympathize with them and go near them, but if no economic contribution from that person, they will start snubbing him. A physician also added, people may move away from them to avoid the financial stress of contributing to their care, which is kind of reflective of the socioeconomic status of the country at the moment. Next, please. Colorectal cancer stigma also had behavioral impacts, which most often led to disease non-disclosure, in turn leading to delays in health seeking, diagnosis, and treatment initiation. Next. And then finally, CRC stigma was felt to have significant psychological impacts stemming from shame and abandonment, which were described to be at times more burdensome than the disease itself. Next, please. Participants described several strategies for mitigating colorectal cancer-related stigma. At the patient level, these strategies included more education about CRC for patients, resources for symptom management, training on coping strategies, and the development of patient support groups. Next. Additionally, suggestions were made for improving caregivers and healthcare providers' abilities to destigmatize cancer care, establish rapport and trust with patients, and model support of people with cancer in the community. Next, please. Lastly, multiple participants emphasized the need for increased community awareness about colorectal cancer, that it exists, that is preventable with screening, and that it is potentially curable with early diagnosis and timely treatment initiation. Next, please. Interestingly, participants also noted a perceived shift in community attitudes and as awareness and outcomes improve, as illustrated by one caregiver who said, using myself as an example, when I see people with cancer, I think they are about dying and that people should not come near them. But when I know that it's not like that, that if one has cancer and goes to a hospital, a good hospital, they'll treat the person successfully. One needs to get close to these people and encourage them, tell them that they won't die. Next, please. So in conclusion, colorectal cancer-related stigma is pervasive and contributes to worse oncologic and survivorship outcomes. However, our findings are encouraging in that they demonstrate a shift in attitudes as positive colorectal cancer outcomes are experienced or observed. Based on our findings, we recommend that interventions aimed at mitigating stigmatization in Southwest Nigeria should be designed with cultural context in mind and should emphasize early diagnosis and treatment programs, support people diagnosed with colorectal cancer with improved resources for symptom management and mental health resources, and empower people diagnosed with colorectal cancer and their caregivers to become community champions for reducing stigmatization and encouraging people in the community to seek healthcare. These efforts will require multi-sectoral buy-in from key stakeholders, as described by several other presenters this morning, but results from studies that have attempted to implement stigma-focused interventions for other types of cancer have shown early feasibility and efficacy, which we believe can be translated to colorectal stigma reduction efforts in Southwest Nigeria. As awareness, treatment uptake, and survival outcomes improve, community attitudes will hopefully continue to shift from one of fear, fatalism, and stigmatization to one of support, solidarity, and advocacy for colorectal cancer survivors. Next, please. And with that, I would like to thank all of our study participants, everyone listed on this slide, and would be happy to take any questions in the Q&A. Thank you.
Thank you very much, Dr. Sivanoff, for a great presentation. I would like to welcome our last speaker for our session before we turn into Q&A. Please join me in welcoming Dr. Douglas DeMolin, a postdoctoral research fellow from Vanderbilt University Medical Center, who will be sharing about psychometric assessments of the impact of event scale revised among Zambian women with cervical cancer. Welcome, Dr. DeMolin. The floor is yours.
Thank you. Are the slides up? Okay, there we go. I'm trying to see if I can advance. Okay, thank you for the welcome. My name is Doug DeMolin. I will be talking about the psychometric assessment of the impact of event scale among Zambian women with cervical cancer. Next, please. Just a brief background of cervical cancer and what's been going on over the past couple decades. The screening program began in 2006, which primarily targeted those that were HIV positive. Now it's become more standardized of looking at cervical cancer among all women. The vaccine was piloted in 2013, where that study found that there was a lack of awareness and lack of percentage of women that have either heard or been screened for cervical cancer. And we're still kind of seeing this being still prevalent within Zambia. But here recently, within the past several years, there's been an increase in the people being screened for cervical cancer, and also improvements in the diagnosis and treatment options of cervical cancer. The big limitation is the lack of validated scales looking at cancer-related PTSD among Zambian women. Next, please. So compared to other countries, the incidence and mortality for cervical cancer is pretty high in Zambia, where the prevalence of late-stage diagnosis is high in Zambia as well. So whenever we look at the incidence and mortality compared to other countries, Zambia is ranked second, and cervical cancer is the main diagnosis or the number one cancer that's more prevalent among women in that country. Next, please. So kind of briefly discussing the field of psychometrics, what this does is it looks at the performance of either a survey, questionnaire, or a measurement instrument, and you're looking at the psychometric properties within that cohort. Next, please. So whenever you look at testing the psychometric properties, you have to establish content validity and construct validity. Because I'm just looking at the performance of an existing scale, what I needed it to do was establish construct validity, which is the empirical assessment of the extent to which empirical indicators measure the construct. This is achieved through unidimensionality, reliability, and validity. Next, please. Next again, please. So this was a large pilot. There was a lot of mental health stuff that was collected, whether it be quality of life, depression, social support, PTSD, stigma, and barriers of treatment. The primary study site was the Cancer Disease Hospital located in Lusaka, Zambia, where we had a total of 221 people that were recruited in this study. The study started in August 2024 and ended in October 2024, and we're looking to expand to have it a longitudinal study. Next, please. So we had a total of 199 women that fully completed the impact of events scale. Unidimensionality was assessed through Spearman's Rho and also confirmatory factor analysis using structural equation modeling. Reliability was assessed through Cronbach's alpha and McDonald's omega, and convergent and divergent validity was assessed through Spearman's Rho, item test, and item rest correlations. Next, please. Next. So kind of briefly looking at the characteristics of the study population, the median values of PTSD was statistically significant by education status, income status, and cancer stage. Next, please. When looking at the reliability of the scale, both the reliability and validity, across all subdomains of the impact of event scale, which would be intrusion, avoidance, hyperarousal, we see these high Cronbach alpha and McDonald omega coefficients, which are high indicators that there is excellent internal consistency, that these are relative measures of PTSD and the respective domains among cervical cancer patients. For the validity, where you see these high correlation values, either in the positive and negative direction, or indicators that that these are convergent, which the correlations being in the positive direction, and divergent correlations being the negative direction. So across all subdomains of the PROMIS scale, we see that there is evidence that these are valid measures and are comparable to other mental health constructs. Next, please. So when looking at the factor loadings, another form of assessment of unidimensionality, we kind of see that for the total impact of events scale that we have high factor loadings across all items besides item 9 and 20, which I can discuss more in the QA if you'd like. We see these patterns when looking at the respective factors by intrusion, avoidance, and hyperarousal, where you can kind of see that there are high factor loadings outside of item 9 and 20, which these are indicators that these items are relative measures of PTSD for cervical cancer patients. Next, please. When looking at the item tests and item rest correlations, which are the correlations of that item if it were added to the scale and if it were removed from the scale respectively, we see that there are high correlation coefficients across all items, still within respect to item 9 and 20, which, like I said, I'll discuss in the QA if there's anything on that. But we do see that these are relative measures of PTSD for each of the item because of these coefficient alphas being above 0.7, and these are strong indicators that each of these items do support the domain of PTSD, whether looking at it unstandardized or standardized formatting. Next, please. And in respect to each of the subdomains, we see that there are still high correlation coefficients, and even with the respective alphas for each of the subdomains of the impact of event scale. And this basically just supports that for these items right here, that they're relative measures and support that respective domain. So like items that you see under intrusion, avoidance, and hyperarousal, these are indicators that these are respective measures of that domain. Next, please. Okay. If you have any questions, I know that was a lot to kind of talk about, but I'm happy to discuss anything in the QA.
Wonderful. Yes, thank you, Dr. DeMolin. And please feel free to add questions in the chat if you have any follow-ups. And now we are going to go ahead and proceed with our Q&A session. I invite our participants to turn their cameras on so that we can have you in our panel conversation. Okay, so we'll go ahead and get started with our questions. So thank you everyone from the audience for adding very relevant questions to our chat. I'm going to do my best to moderate this and have them all together. So our first set of questions are for Ms. Jasmine. And wonder if we could start with, what are the chances of relapse and reoccurrence of pediatric leukemias in Tanzania?
So unfortunately, I do not have the answer to that, but thank you for the question. It's something that we can look for in the future.
No problem. Thank you. Wondering if then you can elaborate a little bit on the social factors, which is another question that is on the chat, that you see have affected the overall annual case detections that you see in your study.
All right. So one of the social factors that affects this is the stigma. So in the past, there has been a lot of cancer education campaigns that were really well-intentioned, but they focus on like adult cancers like breast cancer and cervical cancer. And because of that, one of the unintended consequences is that many people begin to believe that cancer is a disease of adults only. So when you see a child developing symptoms, like a mass in their eye, for example, for retinoblastoma, it was often seen as something as unnatural as a result of like witchcraft or something that the family had done wrong. So because of this stigma, they bring their kid to the witch doctor and not to Bugando. So what the team has done over the years is to basically raise awareness that cancer can affect people of all ages, including children. If you see the symptoms, then they can go to Bugando, and that's why we see more and more kids coming. And I think another factor is that distance. So some families come from areas very far from Bugando, 8-10 hours to go to BMC. And because it's very far, they often do not have the resources, or they don't see it sustainable to keep coming back and forth to Bugando for treatment. But in our current analysis, we see that distance was no longer an issue, or like no longer a significant factor, because of the presence of like the hostel that we have near Bugando, where patients can actually stay whilst they are getting treatments.
Thank you very much for clarifying that. And I think that connects with the next question that's in the chat for you around plans for intervention. So, with these barriers that you've identified, what are some interventions for this young adult cancer patients, and what would be some policy implications that relate to, developing and implementing those interventions? Thank you.
All right, so aside from like continuing the outreach program, the hostel, and so on, We do hope to present this data to the Ministry of Health so that we can advocate for like national programs, like for the retinoblastoma screening, as well as to promote inclusion of pediatric cancer in the National Cancer Control Program. And another thing is that the team is also working on having like a national registry national registry development to look at the trends of pediatric cancer across Tanzania and not just at BMC alone.
Wonderful. Thank you very much. And yeah, if you find anything that you want to add to the chat as well to elaborate, that would be wonderful. The next question that we have, and I'm combining it with one that just came in for Dr. Mone. So there's kudos on using creative ways to educate populations. There is a question around the challenges that we've seen in regards to language from Lake Zone. So yeah, the audience would like to know a little bit more about this. And that might relate with the question that just popped in the chat around how long did it take to evaluate the knowledge changes? Was this immediately after training, or was this 3 or 6 months after that? So yeah, a couple of questions around communications, and then how do you evaluate knowledge changes? That's for you, Dr. Monet. Thank you.
The red zone, my country, the biggest language we are using is Swahili. That's the national language. So almost 70 to 60% of the citizens can understand Swahili. But the large number of red zone citizens speak what we call one language we call Sukuma. So since we knew that not every citizen of the red zone understands proper Swahili, we chose to use those traditional local dancers who speak Sukuma, and also we had what we call a community advisory board. That board had leaders from areas around the area, and those leaders were also speaking the native language, which was Sukuma. And again, for the time, we took 1 month to assess the knowledge.
Okay, great. Thank you, Dr. Monet, for that response. And again, also feel free to add any follow-ups to the chat. The next two questions that we have are for Dr. Sivanov, again, with several kudos for excellent presentation. The first question that we have for you is, are there differences in the degree of perceived stigma comparing males versus female participants of your study?
Again,
sorry.
Dr. Monet, anything else to add? No? Okay. Over to Dr. Sivanov. Thank you.
Thank you for that question. I didn't include it on the slide, but 55% of the patients interviewed were male, 45% were female, and then kind of the same ratio for caregivers, 55% male, 45% female, versus for doctors, it was 80% male, 20% female, and then all nurses were female. But we did notice that women, and this could be due to kind of their role within the society and kind of the patriarchal nature, but they were more likely to describe relationship distancing and abandonment. So the most notable quote that I can think of was one female patient, and I think we included on the slide, but she mentioned that her husband's friends kind of encouraged him to leave her because of the physical changes that took place with her in her body as a result of receiving treatment for colorectal cancer. So I think that kind of ties into some of the themes that we found with regards to social status and who kind of can fund the cancer care. So that was also related. People would often kind of, the abandonment was tied into if they had to contribute financially to patients' care.
Thank you, Dr. Sivanov. There's another question in the chat for you around collaboration. So if you can please go ahead and submit your response there so we can continue with one more question for Dr. Demolin, and then we'll transition into our break. Dr. Demolin, thank you for your amazing study. Was this study done as a standalone project, or was it coordinated with the treatment aspects of cervical cancer and PTSD?
So because this was a large pilot study, the next step is looking longitudinally, because the time of enrollment to cervical cancer diagnosis was narrow. So the exclusion criteria was treatment options if they are already undergoing treatment for cervical cancer. So these are recently diagnosed patients with cervical cancer. So basically, we are at the clinic and they're receiving their cancer diagnosis. Then they're enrolled in the survey, or the study. So that is the next step, is looking at the treatment options and looking at the impact of PTSD and also stigma as well.
Thank you, Dr. Dumont. There's another question in the chat for you. So if you have a moment and you can please go and submit your response there, that would be really helpful. So we're going to go ahead and transition into just a brief closing. And while we wait for our slide on details on accessing the posters, I just want to thank all of our participants, our presenters today, for very insightful and exciting presentations. Thank our audience for great questions. It was a really engaging conversation with lots of really important questions. I would also want to emphasize, the point that was made around that multi-sectoral buy-in, and for us to really think through how we can bring and elevate the voices that need to be incorporated in the research that we do so that our findings continue to be impactful. We will see some details, and we'll share also in the chat a link with some information on accessing the posters that we have available, which also present really impactful research. And we invite everyone to join and visit those electronic posters. And then we're just going to go ahead and transition into our 5-minute break before 3 minutes, actually. I was informed here that it's 3-minute break before we transition into our Pearline Award session. So please join me in thanking our presenters for today for a wonderful presentation. And we will see you in less than 3 minutes for our Pearline Award. Thank you, everyone, for joining today. And please continue to stay here for our next session.
Okay, Franklin, please go ahead. Thank you.
Great. Good morning, everyone. My name is Franklin Huang, and I'm a physician scientist and faculty member here at the University of California, San Francisco, and the co-founder of the nonprofit organization Global Oncology, also based here in San Francisco. I want to thank the NCI Center for Global Health and the organizers for creating and supporting this special session. It is my distinct honor to host this session and welcome you to our presentation of the 2025 Rachel Pearline Global Cancer Award today to Dr. Asim Mansour. This morning, I would like to begin by giving our deepest appreciation to the Pearline family, Don, Rachel's father, and Sarah, Rachel's beloved sister, who are joining this session. Rachel was incredibly close to her father and sister, her family, and her friends, and we deeply appreciate their support of this award each year. Rachel and I grew up together in St. Louis, Missouri, and we were close friends throughout life, sharing a love of our hometown, medicine, global health, and Cardinals baseball. Rachel suffered a loss relatively early in her life when her mother died from breast cancer when she was only 13 years old. And this event, while devastating, guided her future career and passions. While St. Louis was never far from her heart, she graduated from Brown University and then went to Tulane for medical school, where she also received her master's in public health, and then to NYU for internal medicine residency. She then came here to UCSF for hematology and oncology fellowship, where she thrived and distinguished herself in the care of her patients. It was during this time that she was diagnosed with gastric cancer, and she was only 38 when she died from this disease. Our careers closely paralleled each other, and we would often talk about how to combine her interests in global health, oncology, and basic scientific research. She was passionate about global health and caring for the less fortunate, and these motivations were immediately clear to her colleagues. And she was an intrepid and adventurous traveler and worked in China and learned Mandarin. And while she loved to travel, she was still entirely grounded in her upbringing, in her roots, in her friendships, and her family, and still the only person I've ever known who would call her friends on their birthdays without fail. Reflecting her commitment to the practice of medicine, she believed that caring for others was a privilege. And here at UCSF, her presence and absence are still felt to this day. As Rachel faced the adversity of her illness, she was incomparably Rachel, incredibly positive, inspirited, and engaged. She wanted to let everyone in her life know how much they meant to her. And it's best represented in her own words and in her unforgettable smile. There's a video online of her final message, and I encourage you all to watch it. It embodies so much of her spirit. This award was established in Rachel's memory, and every year we honor her memory with this session. And today I'm privileged to present this year's 2025 Rachel Pearline Global Cancer Award to Dr. Asim Mansour. Dr. Mansour is being honored for his commitment and efforts to cancer care in Jordan and the Middle East at large. Dr. Mansour has served as the CEO and Director General of Jordan's King Hussein Cancer Center. KHCC, as it is known, is the largest comprehensive cancer center in the Middle East. And notably, under his leadership, it plays a critical role in providing cancer care to refugees, an underserved and vulnerable population. Through a charity fund and partnerships with various stakeholders, KHCC has become a place of hope for many refugee cancer patients. It is clear from this work that Dr. Mansour has proven to be a visionary leader for cancer care in the region. Dr. Mansour is a board-certified diagnostic radiologist with a subspecialization in neuroradiology and previously chaired the Department of Diagnostic Radiology at KHCC. He's the executive chairman of the Jordan Breast Cancer Program, a board member of the Union for International Cancer Control, and a commissioner for the Lancet Commission on Cancer and Health Systems. Under his leadership, KHCC has attained a number of prestigious recognitions for its nursing, and he has published over 100 peer-reviewed articles and is the author of several books. Dr. Mansour received his MD from Vitebsk Medical Institute in Belarus, fellowship of the Royal College of Radiologists from the Royal College of Radiologists, and Master's in Medical Management from Carnegie Mellon University, and Master's in Science and International Public Health from Liverpool John Moores University. In 2024, Dr. Mansour was awarded the Kuwait Prize in recognition of his exceptional contributions to cancer care. It is my great pleasure and honor to introduce Dr. Mansour. Congratulations on your award, and we look forward to your keynote address today.
Okay. Good morning, though it's afternoon here in Amman. Thank you, Mr. Chairman, for the nice introduction. And really, it's a privilege for me to be here with you today among a group of distinguished scientists and researchers to talk about challenges in cancer care in resource-limited countries, having Jordan as an example. Also, I will try to present the case of King Hussein Cancer Center as a comprehensive cancer center in a country with limited resources, and the role that a comprehensive cancer center can play in advancing cancer care in low resource setting. I'm trying here to advance my slides. I'm not sure if it will work. Yeah, it's okay. Jordan is an Arab country located in the Eastern Mediterranean region with the population of around 11 million, including 3 million of refugees from neighboring countries. It has quite impressive health indicators comparing to countries with similar resources, with life expectancy at birth around 71 years. The unemployment rate is quite high. These are the governmental numbers, though I believe that the true numbers are much bigger. The life expectancy in Jordan has witnessed a significant increase in the past 7 decades, from around 55 in the 60s now to 75 in the present days, which is unprecedented to have 25 years gain in life expectancy in a relatively short period of time. What about cancer? The cancer, according to the last report published by the National Cancer Registry in 2022, around 8,700 new cases were diagnosed with cancer among Jordanians. Also, we have around 3,000 of cases among other nationalities, either refugees or people coming to Jordan for medical tourism. And if the trend continue the same, we expect that by the year 2040, this number will double and the number will reach 20,000 new cases of cancer if the same trend continue until 2040. The population of Jordan is relatively young, and the majority of Jordanians are below the age of 40, and actually 1/3 of Jordanians are below the age of 15. But I think this pyramid started to change with time, and now we started to witness a more westernized type of pyramid where more and more population become aging and above the age of 60 and 65. When it comes to the top cancers in Jordan, as expected, lung cancer is the most common cancer among Jordanian males, followed by colorectal cancer. And the majority of cancers among Jordanian males, if you witness, they are related to lifestyle, and namely tobacco, and I will come to this later, why is tobacco. If you look at bladder cancer, it's number 3, and I think this is unique for Jordan, and this can be explained if we know that bladder cancer is related directly to tobacco. Among Jordanian females, as expected, breast cancer is the most common cancer, followed by colorectal and thyroid cancer. The virus-associated cancers are not highly prevalent in Jordan, where cervical cancer and hepatocellular carcinoma are rare. We diagnose around 50 of each diagnosis, and is different from other neighboring countries. If we take, for example, Saudi Arabia or Egypt, where hepatocellular carcinoma is highly prevalent, it's number 2 or 3 due to high prevalence of hepatitis in these countries. Cancer-related death, lung cancer is responsible for 27% of all cancer-related death in Jordan, followed by colorectal cancer. In females, as expected, breast, followed by leukemia and colorectal cancer. When it comes to challenges, actually challenges to cancer care is all over the world. But I think our countries with limited resources have some specificities related to the geopolitical causes and to the socioeconomic causes also. So I can group the challenges we face in providing cancer care in Jordan into medical service and infrastructure, human resources, quality management and sustainability, public awareness, research challenges, and all of them have some financial burden overarching overall. When we talk about the infrastructure and medical services, the medical services in Jordan are fragmented, and it's not rare that a cancer patient gets diagnosed at one institution, work up at another, and treatment at third. And when we know that these institutions are not interfaced and data are not easily transferred between institutions, we can imagine that this will cause delay in diagnosis, delay in treatment, and poor outcome. Also, cancer care is centralized in Amman, the capital of Jordan, and the big cities with underserved rural areas. Also, we don't have a proper referral system for cancer patients. For human resources, Jordan is well known for well-trained and skilled human resources, but we face a problem of retaining those skilled human resources. They leave country for financial and geopolitical causes. This is why we have shortage in nurses. The turnover among Jordanian nurses is around 30%, which is really a huge burden and challenge. A brain drain among oncologists and other subspecialties is a problem. Also, we don't have enough training programs to replace those who leave country. Quality management and sustainability, the quality of care provided in different institutions in Jordan is not the same. So we have variability in the quality of care, and also the sustainability of care in the time of war around us and in the time of influx of refugees is not sustained. Also, we don't have a cancer control program incorporated within the primary health care. We don't have effective reporting and measuring outcome. This is why we cannot manage mortality and morbidity related to cancer. Public awareness is a problem in Jordan. Actually, the majority of deaths in Jordan and other Arab countries are attributed to NCDs. And cancer is the second most common cause of death in Jordan, contributed to 15% of all cause mortality in Jordan. But the real problem in Jordan is tobacco epidemic. We call tobacco as public health emergency in Jordan. Jordan is among the top 3 countries in the world in the prevalence of tobacco, where 60% of Jordanian males are smokers, 1 out of 6 Jordanian boys are smokers, and 1 out of 14 Jordanian girls are smokers. This is why we have the smoking-associated cancer or attributed cancer are among the top common cancer in Jordan. Also, the disease, the cancer in Jordan is diagnosed at advanced stage. If we take, for example, breast cancer, 45% of Jordanian women are diagnosed in stage 3 and 4. The situation is even worse with colorectal cancer, where 80% of Jordanian patients diagnosed in stage 3 and 4. And if we take our own KFCC data for colon cancer, if we compare our outcome data stage by stage with the data published in Europe and in the States, they are very comparable, and we are proud of that. But if we take all stages combined, you see the difference is big, and this is due to advanced stage at diagnosis, and this is why we have to invest more in awareness and early detection. With lung cancer, the situation is not better at all. What about other risk factors? Jordanians have moved during the past few decades to Western lifestyle. This is why obesity is highly prevalent in Jordan, where more than 60% of Jordanians have body mass index above 25, they're either obese or overweight. Also, the same with the physical activity. Also, the challenges related to awareness, we don't have home care services or psychosocial services integrated within our health system. Also, the same applies to palliative care and survivorship programs. What about research? Research is a problem in all low and middle income countries, where only 8% of all clinical trials related to cancer are being initiated or conducted in countries with limited resources. And the challenges related to research, they are either country-specific or institutional or investigator-related or patient-related. For country, we have several challenges, including the cancer registry, the absence of genetic research, the scarcity of tissue bank in our part of the world. Also, we have a problem with the law prohibiting material transfer for research. If we look at cancer registry, and this is one of the important studies looking at cancer registry in different countries related comparison to their level of income. And it's obvious here that the higher the level of income, the more mature cancer registry in these countries. At the institutional level, we have several also challenges related to research infrastructure, lack of integrating of research training within the medical school and residency curricula. We have problem to access grant money, especially with the high competition with other colleagues from more privileged countries. Also, we have problem to convince pharma to bring investigational drugs to the region. At the investigator level, we have a problem with the knowledge gap due to lack of training or research. Our colleagues, researchers, have very heavy clinical load. They don't have protected time to conduct research. We don't have incentive for research. And the majority of our research is geared toward publication research rather than impact research. Financial burden is a problem all over the world. In Jordan, we spend 84% of our healthcare expenditure on people with chronic diseases, with NCDs, including cancer, and only 16% are being spent on people without chronic disease. The other problem, our healthcare expenditures is geared toward treatment. We spend more on treatment rather than on prevention and early detection, and this is also a problem. To add to the problem, as I have mentioned, that disease is detected at late stage, it's very difficult to treat, the outcome is worse, and it's very expensive to treat. Also, our patient population is young, so this adds to expense. The over-treatment in the absence of clinical practice guidelines is a problem in Jordan and many other similar countries. Waste is a problem also, and also caring for refugees in a country which is a hub for refugees from several countries is also a problem. Just to show you that Jordan is number 2, second to Turkey in terms of hosting refugees, which we host around 3 million refugees. And this is why we established our Goodwill Funds in the foundation, try to help those refugees to get access to cancer treatment. Over the past 20 years, we spent $135 million to treat around 5,000 refugees. And nowadays, the problem is even worse with the war on Gaza. We just received 150 kids with cancer, and those have very complex physical and psychosocial conditions, and this is why it's very difficult to cope with. This is one study I published with my colleagues looking at the outcome of breast cancer, comparing the Jordanian versus Syrian refugees. And it's obvious here that the outcome among Syrian refugees, women with breast cancer, is much inferior due to several factors. Among them, they don't have access to many standard of care breast cancer treatment. Now let's move to the King Hussein Cancer Center and how we contributed to meet the challenges of cancer care in Jordan. In the 90s, cancer care in Jordan was fragmented, and then we established the King Hussein Cancer Center. In 2001, we signed a landmark agreement with the National Cancer Institute of the United States. A new leadership from Jordanians who used to work in the state joined us, like me, the old-timers, the local Jordanians, and we established and we transformed King Hussein Cancer Center into a comprehensive cancer center, not only for treatment, but for cancer control, for early detection and prevention, for research, and for training and education. King Hussein Cancer Center is not for a profit organization governed by the Board of Trustees, where we have the foundation, which is involved in fundraising and development, and the Cancer Center, which is the medical arm. We treat almost 60% of all cancer cases in Jordan. If we take all facilities together, I will come to this later, we treat almost 7,000 new cases per year. 70% of them are Jordanians, and 30% from all over the Arab world. So we are involved in the whole spectrum of cancer control, from prevention to early detection, treatment, palliative care, and survivorship support. In prevention, it's not surprised that we focused on tobacco, and we established our cancer control office with the mandate to understand and manage the risk factors directly linked to incidence of cancer in Jordan, and mainly tobacco. We worked with other NGOs to lobby to enforce the anti-tobacco law, to convince the government to increase the tax on tobacco, and to work on prohibiting smoking in public areas. In early detection, our main focus was breast cancer as the most common cancer in Jordan, through our sistership institution, which is the Jordan Breast Cancer Program, which was established in 2007. We worked on awareness. We've reached each and every village in Jordan. Then we did a pilot study in Amman to study the feasibility of screening in a Jordanian population. After that, we worked on improving infrastructure and quality, and to develop skilled human resources that are able to conduct and read mammography. In treatment, we were the first institution in Jordan to introduce the concept of multi-modality clinics and multi-modality approach to care, where we have for each and every disease-specific a multi-modality team. They have unified treatment approach for the first time in Jordan, and we mandate that for each and every patient, we have a pathology and radiology review in-house. And also we developed process and outcome indicators for each and every service. We also established niche programs. We started with a bone marrow transplant program, which is one of the most successful in the region. It was established in 2003, and year after year, we added new, more complex procedures until in 2025, just a few months ago, we are proud to be the first institution in Jordan to introduce for the first time CAR T cell to the Jordanian people. So far, we have transplanted more than 3,000 adult and pediatric patients from Jordan and abroad. This is not enough. We have to improve access to care and equity to care. This is why we embarked on the partnership with the Jordanian government, with the Ministry of Health, and we opened a small outpatient cancer care facility at the eastern part of Amman, which is underprivileged part of Amman. And so far, we treated 3,000 new cases with cancers from underprivileged population according to the highest standard. Also, we moved to the south and we inaugurated our Aqaba branch, which is in the southern part of Jordan. Again, it's also an outpatient facility with early detection, screening, and a treatment for outpatient chemotherapy. For research, we came up with the research priorities to reduce the burden of patients presenting with advanced stage, which is tailored to our local challenges, also to improve access and affordability, to put more emphasis on technology assessment and health technology assessment, and to provide our patients with cost-effective interventions, also to scale up the quality of care and to improve cancer control. This is why we established our cancer research office, governed by three bodies: the Research Council, which is responsible for strategy and scientific review, the Research Office, which is responsible for the infrastructure, and the IRB, responsible for ethical review. Also, we established for the first time in Jordan and probably in the region, our hospital-based cancer registry, which is very rich in outcome data. Nowadays, we have 80,000 index cases, which is really rich area for research, not only for KICC, but the whole Jordan. Also, we built a rich network of collaboration with institutions from all over the world, both hospitals and research institutions like AORTIC, which is the largest European organization for research, and we lead their effort in the Middle East, with many clinical trials are being conducted in the Middle East through this Middle Eastern office of AORTIC. This has also resulted in increase in number of research applications and submissions at KICC over time, and also in the number of cumulative clinical trials, which represent a wide range of clinical trials from phase 1 to phase 4 clinical trials, both investigator-initiated or pharma-sponsored or as part of international collaboration. Finally, when it comes to the human resources, cancer care is a human resource intense organization. If we take King Hussein Cancer Center, we have more than 440 physicians, more than 1,200 nurses, 150 pharmacists, including clinical pharmacists. And to do that, we need strong training programs to compensate for those colleagues who leave the country due to high turnover, as I mentioned in the prior slides. This is why we established our own in-house training programs covering all specialties and subspecialties, including medical oncology, surgical oncology, radiation oncology, internal medicine, general surgery, anesthesia. And we train people not only for Jordan, but for all over Arab world and even the world. Now, the graduates of these programs are working in more than 20 countries in all continents, and these are the specialties where we have a training program. Also, we have diplomas for palliative care, for respiratory therapy, for pain management, and not only for physicians, also we established our residency and internship for pharmacy and for oncology pharmacy. Actually, we established this specialty for Jordan and for the Arab world. Also, we established in collaboration with the ANCC, the first of its kind cancer nursing residency program, which is a one-year program to prepare Jordanian nurses to be ready to work and to provide cancer care. This has resulted in a rich experience which we published a few years ago with my colleagues, how the Jordanian practice, how to manage brain drain through brain drain. So in conclusion, cancer burden in countries with limited resources is an ongoing problem that will increase with time due to aging population and increase and high prevalence of risk factors. Our patients still presenting in advanced stage. This has resulted in low cure rate and high cost. We need country or region specific data to manage our risk factors. We have to manage brain drain through strong training programs. We have to establish centers of excellence to be the spearhead of cancer control in our countries. International collaboration is key for capacity building and knowledge transfer. Here I will stop, and I will thank you for inviting me to speak in front of this distinguished group of people. And my email will be shared through the website. If you have any questions, I will be happy to answer after the session via email. And thank you again.
Thank you, Dr. Mansour. That was fantastic, and we congratulate you again on your award. Please feel free to answer questions in the chat. There are one or two in there. And now I'll turn it over to Laura S. Fowler to close our session. And thank you again for all for joining.
Thank you very much. Hello, everyone. My name is Laura Usfeller, and I am deeply honored to be here with you today as a patient advocate, a kidney cancer survivor, and a proud member of the steering committee for this symposium. Today has been remarkable. We have heard presentations that span disciplines, geographies, and perspectives, but with one shared goal: reducing the global burden of cancer and improving outcomes for patients everywhere. I've personally been humbled today at how universal cancer can be, and I have my own takeaways from the conversations on what may seem to be hyper-localized situations, but they cross international borders. Rural breast cancer patients in Ghana facing barriers to diagnosis and care, and colorectal cancer patients in Nigeria sadly feeling shame about their diagnosis, indeed have a lot in common with patients here in the United States and across the globe. The knowledge, collaboration, and ideas exchanged today will ripple far beyond this meeting into labs, clinics, communities, and ultimately into the lives of patients like me. This symposium is not important just in theory to me, but it's personal. I am alive today because of research. 9 years ago, I was diagnosed with stage 4 papillary renal cell carcinoma, and I enrolled in a National Cancer Institute sponsored clinical trial through SWOG Cancer Research Network, where I received a targeted therapy drug known as cabozantinib, and that trial gave me access to treatment that ultimately led to complete response, and I've been off treatment and cancer-free for 5 years now. Clinical research saved my life, and my story is proof of what happens with innovation, science, and patient access come together. Every breakthrough represented today has the potential to transform a patient's story just like mine. That's why today's symposium is so vital. Cancer is not bound by borders, and neither should cancer treatment and research be. When we share knowledge globally, whether it's about novel treatments, health system solutions, or approaches to equity, we accelerate progress. And equity in cancer care is not optional, it's essential. Patients will live longer, healthier lives specifically because of what we shared with each other today. The work that you all are doing reaches far beyond your own institutions or countries. It impacts people like me across the globe, and patients you may never meet will benefit from because you chose to collaborate today. I also want to pause here to thank my colleagues on the ASGCR steering committee for including patient advocates like myself in the planning of the symposium. That decision reflects a fundamental truth that patients belong in research. We often say in patient advocacy, no decisions about us without us. Our experiences as patients are valuable and irreplaceable. When scientists and patients work together in research, we move the field forward in ways that science alone cannot. Patient advocates aren't just storytellers. We are partners in advancing research. For example, I've had the privilege to contribute to trial design by suggesting changes to improve accrual and retention, such as adjustments to change scan schedules, reimbursements for travel and parking, or flexibility in treatment options when clinically appropriate. And these changes may seem small, but they can make a big difference in a patient joining and staying in a trial. Most patients want to give back and contribute, and we want to give purpose to our lived experiences. Including us not only honors that desire, but it also strengthens your research. So, as I thank you all, our speakers, our participants, my fellow steering committee members, and abstract reviewers, please know that your contributions are not just abstract. They directly translate into lives changed, families preserved, and hope restored. On behalf of patients everywhere, I thank you today. Before you log off, we would love your feedback. So please, if you could take a few minutes to complete the post-symposium survey by scanning the QR code or using the link in the chat. And your input today ensures that this symposium continues to grow and serve this global community. I'm also excited to invite you to join us in 2026 for our 14th annual symposium on global cancer research. We'll be sharing dates and a call for proposals soon. But in the meantime, please stay connected with the NCI Center for Global Health through the website, LinkedIn page, and the CGH Exchange newsletter. Finally, as we close today, please let's remember that the fight against cancer is global, and it takes all of us, scientists, physicians, patient advocates, policymakers, and our fellow patients working together. I stand here today as living proof of the power of research and collaboration. Please help me to keep patients at the center of your work. Invite us to the table, partner with us, and continue to share knowledge across borders, because when we do, patients everywhere will live longer and better lives. Thank you to your dedication, your participation today, and your compassion for the patients that you serve. I can't wait to see what we accomplish by the time that we've met again in 2026. Thank you.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.